All right, guys, I am so excited that you're here. Welcome to this month's live Q&A, our session on hormone and mood sensitivity. I am so glad that you have made time for this. This is going to be some practice-changing intel for you today, as always. This is what our goal is whenever we work with you at the Confident Clinician, is that the intel and the info that you gain from spending this time together today gets implemented into your practice right away. We're talking about information and research that has just been published and should be in your practice starting tomorrow. And so I know that you're going to get a ton of value, have some really great takeaways. We're going to give you some scripting that you can use with your patients starting tomorrow or starting this afternoon, depending on what time zone you are tuning in from. All right, so we're going to kick it off. And today we're talking about a topic that is near and dear to my heart and near and dear to my career. And we're talking about hormone sensitivity and mood changes. So welcome. I am Dr. Jordan Robertson. And if we haven't had the chance to meet, I am the founder and the lead educator at the Confident Clinician. We are a practice resource and clinical decision-making tool for integrative practitioners, naturopathic doctors. My career in this conversation around hormone sensitivity and mood spans multiple decades, actually, with lots of opportunities to treat patients. I've worked with over 10,000 patients with hormone-based mood challenges, taught on lots of stages, whether that's medical schools, pharmacy schools, the naturopathic colleges, the naturopathic associations, been on lots of podcasts, and also have had the great I'll say fortune of working with lots of amazing professionals on my podcast, Real Integrative Medicine, where I've been able to host some really amazing speakers and authors on that stage. People like Stacey Sims, people like Heather Hirsch, gynecologists, people from medicine, people like Celine Yeager from Feisty Menopause. I've worked with a lot of these professionals over time around this discussion around mood and hormones and hormone sensitivity. And one of the reasons I've been able to have so many cool opportunities like that is because of how evidence-informed my work is and how much time I've spent on this particular topic. And so if it's okay with you, I would love to spend the next 45 minutes helping you understand how to be an expert at this. I promise I will teach you everything I know about hormone-based mood sensitivity and how this impacts your patients, and also how to think about it in terms of practice. I promise I'll teach you everything I know about this, including the assessment component. All that I ask, and I'm going to ask if you say okay to this, is that at the end of the session, after I've shared everything I know about this, is that you let me give you the opportunity to learn about the Confident Clinician and share with you about how we can support you in your practice. And so I hope that's okay with you. If you can throw a big yes, Jordan, in the chat. Happy to share all of this information about hormone-based sensitivity. But at the end of the session, I am going to invite you to how to work with us in a deeper way and how you can get access to content like this every day in your practice. So when I work with clinicians, I essentially have a three-part framework that I am working through. I deeply want you to understand the research. So my background is in critical appraisal. That's how do we take research from trials and put it into clinical care, okay? Not every study that's published belongs in medicine, but some of them do. And how we make that decision and how we do that is a skill. And I deeply want you to understand the research to know how we make those decisions and what belongs in your practice. I also want you to leave every learning opportunity with a tactical blueprint that you can use in your practice today. I'm sure we've all been to lots of talks where there isn't a whole lot of take-home nuggets that you can put into practice. Your time is valuable. If you're going to spend an hour with me, I want to change the trajectory of your work for maybe years to come. And so I want you to walk away from this session today and any session you have with me or us with a blueprint on how to plug this into practice right away. That should save you time just by listening to this session. But I also want you to develop a level of mastery and some language to support you in your day-to-day work. It's not enough to know what we know, but we have to have the skills to be able to communicate it to our patients online in places where you're invited to speak. And so I want you to borrow the language I use today to describe these challenges and plug them into your practice right away. Take the phrases, take the metaphors, take the examples, and use them with your patients. So whenever I'm working with clinicians, I always think about things from this sort of triangle where how do I give you the research, give you a tactical blueprint that you can use and a standard of care to work from, but also give you the communication, language, and level of mastery so that you can be the expert at this in your community. So that's what we're going to tackle in our session today. I've always posed this question when speaking to clinicians, and I think those of you in the integrative medicine space can really resonate with those scenarios where patients have fallen in a crack between two subspecialties. And hormone-related mood challenges are a perfect example of a patient falling right in between gynecology and psychology or psychiatry, with nobody really taking ownership or responsibility over the assessment or the treatment of this patient. So I always say, is it the psychiatrist's job to look at hormones or the gynecologist's job to diagnose depression? You'll understand if you work with these patients that these patients often flounder around for a long time before someone's able to make that connection across those two specialties for them. And you are probably having that role with patients every day. Now, when we look at this chart, and I'm sure this chart is burned into your brain since school, I want you to be able to teach your patients how hormones are impacting their mood so that they deeply understand and connect with the treatment plan that you're going to provide them that actually helps them recover from hormone-related mood challenges. Now, of course, we all recognize this, our beautiful estrogen peaking in the middle. We've got our pink estrogen, and we've got our blue progesterone here. And what I want you to walk away from today is this undisputed fact that it's not the numbers that these hormones rise up to or fall down to that create the challenge related to mood. It is the change in hormones, the delta in hormones that make the difference for why someone's brain has mood symptoms related to their hormones. Now, if you've worked in the hormone space long enough, it probably feels most of the time like your patient's hormones are doing something like this, or at least that's how it feels on the receiving end for your patient. But what I want you to understand deeply after today, and what I want you to teach your patients, is that it's the transition from low hormones to high hormones and then back down at the end of the cycle that puts pressure on the brain and creates hormone-driven mood symptoms. So let's talk through the research on why this is. If this is a new concept for you, this is going to be really important. If this is something you are already kind of aware of, I want you to understand where the research sits at this point and why we are so sure of ourselves that it's the change in hormones that makes the difference, not the absolute number of the hormones that makes the difference. So we've always known that there's a connection between hormones and mood, right? We see it in many scenarios. We see it in many life phases. Where we've struggled is to pinpoint, well, what number do these hormones have to be in order for our patient to not feel well? And truly, when it comes to making diagnoses in medicine, we love cutoffs, right? We love to say, over this number and things aren't good, or below this number and that's where you get symptoms. And so we've always struggled with hormonal concerns because many of the symptoms associated with hormonal health are not about that absolute number. So we could test 100 patients and not be able to pick out who has PMS. They all have very similar lab work on day 21, and yet some of them have PMS and some of them don't. So what we've always struggled with is linking up that absolute hormone number with the symptoms that patients feel. So despite us being really clear that hormone transition times, whether it's postpartum or perimenopause or menopause or PMS, hormone transition times do create symptoms, but what we've not been able to do is pinpoint what number causes those symptoms. We also know that if we just get rid of hormones, right? I always say take them out at the knees with a medication, that we eliminate many of those hormone symptoms. And so what is it about hormones that are actually causing the symptoms? If we know they have to be there for the symptoms to be there, and yet we can't pinpoint a number on lab work, which is very frustrating and not the way that medicine typically likes to operate. And as we start to examine each of these hormone phases, whether it's menopause or perimenopause, what we've noticed in the literature is that the absolute number doesn't matter. What matters is that person's change from what their absolute normal levels are to the new levels that makes the biggest difference. So this example I have here is in menopause, and looking at people's risk of depression over a period of a decade is that wasn't the number that caused depression, but it was her own change in hormone levels over her course of menopause that was the risk associated with depression. So only the change in FSH, the change in estradiol was associated with depression onset, not the absolute number. Okay, looking at another scenario, this is one looking specifically at people in the menopause transition. Again, what they found when tracking all of their periods over the course of 8 years, that again, it wasn't the number of the hormone that made the difference, but her change relative to her own normal in the premenopause phase that actually increased the risk for depression. So again, not the number, but that delta that is supposed to be, that changes the the way that that person feels. Okay, so looking at this paper, when we suppress ovulation in people who have PMDD, we notice that we actually can eliminate their symptoms. So in this particular paper, what they took, and for people who have PMDD, we know, and you can see here on the slide, okay, this is a 2017 paper. In people who have PMDD, when we suppress ovulation, we can actually eliminate their mood-related symptoms. Okay, so if we eliminate their hormones, then we can eliminate their symptoms. What they did in this paper was actually quite fascinating, because when we've studied PMDD in the past, we've assumed that it was the high hormone levels of the luteal phase that were causing the issue, okay? And so what they thought was, or what they expected was, if they medicated those patients up to a luteal phase level, okay? So they suppressed them with medication, and then they medicated them up to a luteal phase level. What they assumed is that they would trigger the symptoms of PMDD, and that person would keep having symptoms of PMDD as long as they were medicated. But that's not actually what happened. What happened was that they suppressed their ovulation, so they improved their symptoms. They then medicated them up to luteal levels, okay? They medicated them up to luteal levels of progesterone and estrogen. Now, in that very first month, those people had symptoms. In the very first month, their PMDD symptoms returned. They kept medicating them as they went along. They kept medicating them, and guess what? Their symptoms went away. So if we thought it was about the number, then medicating them up to this number, which had previously caused lots of symptoms when they were cycling on their own, if we medicated them up into this number and left them up there, we would assume that they would feel terrible all the time. But they only felt terrible in the first month that we took them from 0 to luteal. Then they felt terrible. And if we stabilized their hormone levels at the top, they actually improved and stayed well as long as their hormone levels stayed constant. Okay? So you can see I'm building a case for us here. You can see that in the menopause transition, it's not the number, it's the change. Okay? We can see in PMDD, it's not the number, it's the change. When we've looked at some of the newer theories on things like PMDD, again, we're seeing that same piece. It's not the number, it's the change. Okay, here's an example in perimenopause. Okay, they've looked specifically at estrogen sensitivity in people in menopause and in perimenopause. And what they found is that actually the less resilient that person was as they transitioned into menopause, the more sensitive they were likely to be to those changes in estrogen. Okay, so we're starting to understand this better, to say that why, for some people's brains, would that change in hormones be inconsequential? Right? And I always say to my patients, do you remember ovulating when you were 14? Nobody remembers ovulating when they were 14, right? Life was good. Things were relatively easy. No one remembers ovulating when they were 14. But as we pile on years of stress and maybe health negligence and trauma, suddenly at 44, ovulation is a big deal in the brain. Right? That less resilient brain at 44 finds ovulation quite stressful. So in this particular paper, this Willie paper, which I adore, looked specifically at the risk factors that were associated with depression in perimenopause. And the things that they found were, some of them unsurprising: stress, right? Hot flashes and insomnia, right? I think we could have guessed those. But the fourth most important was the deviation from her normal estrogen pre-perimenopause. So again, the change in hormones became one of the greatest risk factors for mood changes in perimenopause, right up there with stress. So our most recent paper, and this one was just published, and this is the one I really want to influence the way you think about your patients and the way you think about practice, because it does a great job of summarizing this case I've been building for you over the last couple of slides. I'm sure, and have you ever had a patient in practice where they get worse during the luteal phase? Right? I'm sure you will all say yes. Have you ever had a patient whose mood gets worse in the luteal phase? Now, have you ever had a patient whose mood gets worse when their period starts? Probably. So what's with that? Right? Why is that happening? We always assumed under our old model of PMS that if hormones were high and that was the problem, as soon as they went away, everyone should feel great, but not everyone does. And then we've also all had those patients where they got worse at ovulation and then they kind of stabilized. Well, what was with that, right? Typically, we imagine ovulation being a time where people feel quite well under the old model of PMS, right? But what we really understand is that there are subtypes of patients. And there are patients that are responding differently to the different changes that are happening with their hormones based on the sensitivity of their brain to the change. So going up at ovulation is a trigger for some patients. Being up there in the luteal phase is a trigger for some patients. And the fall down into the next cycle is a trigger for some patients. And what this Peters paper has done for us so beautifully is start to articulate what we maybe have noticed in practice all along, right? We've all had those patients where we're like, how do you feel during your luteal phase? And the patient's like, oh, I feel fine. But as soon as my period starts, that's when the depression hits. And you're like, well, this doesn't match like what I learned in school. Like this doesn't match what we've thought all along. And it's really because what we're acknowledging now is that the change in hormones is what's putting the pressure on mood and putting the pressure on the brain. So in the Peters paper, she offers this wonderful summary, and I adored this paper so much I emailed the author to tell her how thankful I was for her contribution to science. And if you've never done that, email your favorite author and tell them how great their work is and how much it's changed the way you practice medicine. I'm sure they don't get enough thank yous in the work that they do, but I emailed Jessica Peters to tell her thank you for this paper and how important it is in the work of hormone sensitivity and mood. But essentially, and I have a diagram from the paper to show you in a little bit, but we suspect that there are patients that are sensitive to the rise in hormones at ovulation, that are sensitive to higher levels of progesterone and estrogen. That's our very classic PMS and PMDD picture. And then we have patients who are more sensitive to the drop in estrogen that's happening at menstruation. And what this paper does such a beautiful job of is start to explain from a neurochemical perspective what may be happening in these patients and why they don't all feel the same, which starts to point towards the possibility of different treatment options for them. So in our patients who have that very classic PMS, elevated symptoms when they have elevated hormones or higher levels of hormones, that they tend to be more irritable, more sensitive, they have more emotional lability, right? They're sensitive to rejection. They may be more reactive. Whereas patients who struggle more during that low estrogen phase or as they slide into the next menstrual cycle have overall more negative affect. In patients who are at risk for suicide, this is where we have the highest number of suicide attempts, is during that low estrogen, low mood, depressed state. This is more menopause-like mood symptoms. And then the group we know the least about, but I'm sure we'll know more soon, is the group that feels the worst at ovulation when we get that high estrogen surge. And it's suspected that those comorbid conditions that are related to impulsivity or risk-taking behavior or substance abuse actually are the ones that are the most likely to face increased pressure during that phase of the menstrual cycle. So following along the story here is that it's not how high someone's estrogen is that affects their mood symptoms. And I hope we can all agree by the end of this session that the number up here, maybe testing this number up here, is not helping us understand our patient any more than just observing the way that they feel during phase to phase of the menstrual cycle. So like I said earlier, it's that transition from low to high, from high to low, that seems to impact the way that patients feel versus that absolute number. What happens in perimenopause to bridge those two discussions, right? We've got high hormones or that low to high during ovulatory cycles. You maybe can see it in menopause when we get into low estrogen, that that's going to put pressure on the brain in a different way and the onset of new estrogen, low estrogen symptoms. When we are in perimenopause, we've got sort of two potential scenarios. Although I think the hormones in perimenopause much better are resembled for that earlier picture or diagram I showed you with all the lines everywhere. At least that's how patients feel. But in perimenopause, as we get that like strong FSH drive, we may end up with loop cycles or luteal out of phase ovulations where patients may ovulate more than once in a month. Okay, so we may end up with multiple estrogen and progesterone surges through the month. And so this is where patients may start to feel a little unwell all the time, or it may feel out of sync with their menstrual cycle, but now their hormones are a little out of sync with the menstrual cycle. So some of the culprits around that PMS feeling in perimenopause may be the extra ovulations that people experience in the cycle, but it may also be triggered by some anovulatory months that will happen in a perimenopause patient where they have no hormone production or very little hormone production, and they may again have more episodes of low estrogen and low estrogen mood during those months because of those changes to the menstrual cycle. Now, this is the diagram that comes out of that Peters paper. They've got day 14 as the beginning of this chart here, which always throws everybody off when we're used to that being day 1. But that estrogen and progesterone surge around day 14 or halfway through the menstrual cycle is where that sort of classic PMS, PMDD symptoms start to creep in. And those patients are responding to the elevated levels of progesterone, elevated levels of allopregnanolone. We've got that second cohort that is struggling when estrogen levels fall into the next cycle. These are patients that are perhaps presenting more often with more depressed-like symptoms. And then we have, again, that group that we know the least about, but we know they exist, that do seem to have a worsening of their symptoms around ovulation. Okay? So I hope you're with me so far. It's that the line change, the change from low to high, is what puts that pressure on the brain, which increases the risk of mood symptoms in those patients. So it certainly begs the question about whether or not we test. I showed you all the way along that we have never been able to peg symptoms against numbers. We've never been able to test and predict risk the very things that increase risk of mood-related changes with respect to hormones have much more to do with resiliency, have much more to do with general health and state, have much more to do with the change than they ever have with the actual number. So this newer understanding certainly begs a couple of questions when it comes to assessment. And this is what I want you to feel really confident in when you leave our session today, is that you're really confident in how to assess your patient with mood-related hormone challenges. Okay, so why are we testing if we don't understand how to use the numbers, right? If her estrogen is 1300 or 1100 or 700, it doesn't seem to influence her symptoms the way that the rest of her health and life and resiliency actually does. Okay, so testing either needs to tell us something we don't already know, or it needs to really inform our treatment. And if it doesn't help us diagnose this person, and it doesn't inform how to treat them, it begs the question whether or not we should be testing at all. This is a clinical diagnosis. It is not one that's made through lab work. Tests don't help us if we're talking about a sensitivity to normal numbers. I'm going to say that again. Testing doesn't help when we're talking about a sensitivity to normal numbers. And you're going to say this to your patients. If we are going to test your patient, then it has to focus on differentially diagnosing them for conditions that look an awful lot like this, but maybe aren't this. Things like low thyroid, right? Or low iron, or sleep apnea, right? There are a lot of conditions that will mimic the hormone-related mood challenges that your patient may be facing. Testing actually needs to be about a differential diagnosis versus trying to peg down why your patient doesn't feel well around ovulation. So this is pulled from this great paper, the Bromberger paper, which looked at all of the risk factors associated with mood challenges related to hormones. And in this, they were looking at like a middle-aged and above population, but the data is consistent when we look at people who are at risk for PMS and PMDD, the same factors apply. Right? There are many biological contributors, specifically genetics and also epigenetics. This is where you have a profound impact, is that there's a lot of health-related behaviors that will impact how someone's mood is affected by their hormones. Okay? And then we also have this psychosocial model of how hormones and mood intersect, where we know that stress, trauma, adverse childhood events, socioeconomic status have a significant impact on how resilient the brain feels against ovulation. So there's lots we can do to support these patients. It's understanding the root of why they don't feel well that's so important. Remember, it's that the brain is perceiving a normal variation in hormones to be a threat. The hormone levels are normal, but that's not how the patient experiences it. So your take-home tactical blueprint here is that, one, you're going to use testing for differential diagnosis of other non-hormonal conditions, okay? There are lots of things that will mimic the symptoms in your patients, and there's also lots of comorbid situations that are going to worsen hormone-related mood challenges as well. So vitamin D deficiency, anemia, PCOS, they're all going to worsen that hormone-related mood sensitivity, and you may use testing to help identify those patients or rule out or rule in other comorbid conditions that are going to make this experience worse for your patient. That's number one, right, of your assessment. Number two is educating your patient about the phases of their cycle, which I'm sure you all do, but help them understand and maybe have language to describe the way that they feel so they can do a better job communicating with you. One of the biggest challenges in making hormone-related mood diagnoses is that it relies so much on symptom recall from your patient. You need them to tell you about their last month or their last 3 months. So educating your patient about how they may feel, the different phases of the cycle, what to be mindful of, and how to take a good track record of their symptoms goes a long way in helping them understand their symptoms, and it also helps you track and monitor their progress. And then the third piece is applying treatment that specifically supports your patient's subtype. So we know, for example, when patients are given hormone replacement therapy, that it decreases the change, right? It decreases that delta, and we see improvement in mood in perimenopause, in menopause, by decreasing the fluctuation of hormones by adding things like hormone replacement therapy. We also know that things that build resiliency and improve mental health, whether that's cognitive behavioral therapy or exercise or stress reduction, compassion-based training, all improve the resiliency of the brain. So the hormone levels may stay the same and may just do their natural fluctuating thing, but now they're doing it in the presence of a more resilient, stronger nervous system. And that stressor is going to be less experienced by your patient if we build more resiliency in their brain. So how are you going to take this home? And I would say the most difficult part about treating hormone-related mood conditions is countering the misinformation that your patient has heard up until the moment that they're across from you at the table. So communicating to your patient that their body is individualized and unique and is responding to their hormones in a unique way is actually relatively easy. And I think your menstruating patients will intuitively understand and know that. The challenge is by the time they get across from you at the table, they've heard that they should test their hormones. They've heard they should detoxify their hormones. They've heard that one of the two hormones is terrible and the other hormone is, a gift from the universe that's going to save them and solve all their problems. And now here you are trying to set the record straight and to try and help them understand that their hormones are fine, that their brain is responding to the change, and the path through is probably resilience-based training, as well as maybe some hormonal support in the form of hormone replacement therapy. So we've given you some language here that you can try on and use with your patients. This is going to sound crazy, but your hormones are actually normal, and testing them isn't going to help us understand your diagnosis at this point. What we need to do is build resiliency in your brain. Okay, your brain and body are having a stress response to your hormone changes, and that's why you feel the way you feel, but your ovulation is happening the way that it's intended and your hormone levels are normal. I always use the example, do you remember ovulating when you were 14, when life was simple and all we did was watch after-school shows and didn't have a lot of homework? Probably not. It's when we layer on the years of stress and challenge where ovulation becomes more noticeable. It's the same hormonal event when you're 14, when you're 44. It's that your brain has decided that life is a little more stressful at 44 and it feels different at this time. So here you can take any of these phrases. Our goal is to build strength in all areas so this stressor is no longer a stressor. We're not here to change your numbers. We're here to change the way your brain responds to those numbers. And the goal, if you use HRT, is to reduce the delta that you feel each month. Some months you are going to make some hormones in perimenopause, and some months you're not. Hormone replacement therapy decreases that risk of mood changes because it decreases the fluctuation and the change. It decreases the extremes. Okay, are you with me? Yes, yes. Let's see some yeses in the chat. I hope that this is helpful, right? Because it really sets the record straight that one, you don't need to test hormones. And before you, but me, of course, there's going to be scenarios where you test hormones to differentially diagnose things like premature ovarian failure or PCOS. But I'm talking specifically testing hormones to understand mood-related changes is not necessary, okay? You are more than welcome to test hormones if you're trying to differentially diagnose another endocrine disorder, but testing hormones specifically to understand mood is not indicated, okay? The tests that you need to run if your patient has mood-related hormone changes are about a differential diagnosis, right? It's like testing thyroid, testing vitamin D, testing for PCOS. Maybe it's testing for other conditions that mimic the fatigue, the irritability, the not feeling like themselves, feeling, like their mood shifts all the time. You're testing for other things, okay? So hopefully you can see the value in that. I hope that it also points out that not only that you want to be a hormone doctor, but now actually you have to be an everything doctor. So this is one of the challenges with working in hormonal health, right? It's this subspecialty that actually you need to be pretty darn good at everything. Now we're not just looking at hormones, but we're seeing that hormones are creating a stressor in your body. We need to build resiliency, but we also need to differentially diagnose you with a whole whack of other medical conditions that we may also need to support so that your hormones don't influence the way that you feel every day, right? So now we have we understand the hormone piece, but now you actually just have to be good at everything if you want to support patients with hormone-related mood challenges. So I would love to take the next couple of slides to talk to you a little bit about the Confident Clinician. And when we built this practice resource, it was to save you time. It was to help you practice smarter. We've never had a resource for clinical decision-making before in integrative medicine. And we also wanted the practice of integrative medicine to have the standards raised and for you to practice at a very high level with your patients. And when we built this system, it was around this entire framework that the results we wanted you to feel was that it was more efficient, it was more streamlined, you knew what to do, you could show up confidently, and you were a better doctor all at the same time. And over the last 5 years, we have been incredibly successful at being able to support clinicians just like you. We've been able to take this tactical framework of here's the language, here's how to do it, here's how to plug it into your practice right this second, and transformed the lives of hundreds and hundreds and hundreds of integrative practitioners, whether they had just walked out of school 1 day ago or they've been in practice for 20 years. We're meeting them exactly at that intersection between them wanting to provide better care for their patients, but needing more support in clinical decision-making. We really deserve that level of support like every other healthcare practitioner that's out there. We have been the ones that have not had this resource all along, and really we made it your responsibility to do all of this research yourself. So when we built the Confident Clinician, we built it off of a 4-pillar system where we wanted you to have our knowledge and access to a database and knowledge base. We want you to have these take-home tactical blueprints that you can plug into your office right away. We're building a standard of care that you can refer back to always when you're working with patients that combines both personalized medicine and a standard of care, which you can do both, trust me. And we also wanted you to feel like you were part of a community. So when working with our patient who has hormone-related mood sensitivity and we need support in making that differential diagnosis, that resource is right there at your fingertips to tell you exactly which lab tests to do and how to support your patient, but also how to think through complicated medical decisions. How do I make a decision if this is a hormone-related mood condition? And how do I make a decision about whether or not this is something else? We build our knowledge and repository through all of our live trainings, through all of our mentorship. And so what's unique about what we do is that we want you to have the level of confidence and ability to deliver this in your practice the same way that you feel right now about that conversation we just had about hormones and mood. Where tomorrow, if someone walks through your door with PMS, you have a new and different and more confident way of describing this to your patient. If someone knocks on your door and says they'd really like to have their hormones tested, you have some new language and new evidence for why that's not the first step that you need to take. So our knowledge and database is actually built through many, many, many hundreds of lectures and inputs through our research teams so that you have the information that you need right at your fingertips. We keep it up to date. We include our conversations. So not only are you getting the study summaries, but you're also getting the interpretation. You're also getting the dialogue. You're also getting the mentorship. Everything we build is archived for you so that you can access it at a moment's notice when you're with a patient. If you've ever been working with a patient in your niche and have them walk in and say they had a new diagnosis of asthma and you think to yourself, oh gosh, I just got assigned 3 hours of homework this evening. This is going to change your life and change the way you feel about practicing medicine, because you'll feel so much more confident and so much more engaged in your patient's care, knowing that you never have to turn someone down or stay late at work to actually get the job done. So these are snapshots I pulled from our burnout module, which we just completed with the Confident Clinician, where we're supporting things around differential diagnosis, but also delivery of care. Now, I don't know if this is you or not, but I always found practice pretty lonely. There's not a lot of space in our work where we have the opportunity to share, connect, collaborate, or even turn to someone and ask if you're doing something right. And one of the things we've built at TCC is that you have accessible dialogue with people in the community. Our lectures are actually all delivered live. And so if you wanted to show up and ask your specific question, you can. The goal of our work is that it feels like evidence in motion. So we're having conversations, we're changing things as they happen, but you also get to harness the clinical experience of the person behind the mic by being able to ask their questions. So this is an example again from our burnout module. I chose the slide on caffeine and cortisol because that was a big discussion that happened in the community. But this is real-time engagement and real-time conversations we're having with our members to support them in their clinical practice every day. And like I said, I truly believe that there should be a standard of care and this ability for you to practice personalized medicine. And so one of the ways that we do this is by giving you the evidence in terms of what that standard looks like, but then also helping you work through the complexity of decision-making in medicine. Not every paper belongs in your practice, and having study summaries on ashwagandha doesn't really help you know when to prescribe it and who you should avoid it in. And so when we support our clinicians with that decision making, it's always through the framework of how do you do this in your practice? When would you prescribe this? How would you make this consideration? So again, these are screenshots from our burnout module that show you that we're not just summarizing the studies, but we're also helping you contextualize how to build a treatment plan that's going to be the most effective. Again, I showed you an example from our smart search bar. You can actually ask it to make treatment comparisons for you and say, when would I do this versus doing this? And it listens to all of the dialogue we've ever had inside of our community and gives you a really great answer in less than 10 seconds. The last thing I want to share is what's so important is this idea of a tactical blueprint. So what's missing in research is the how in medicine. Standards of care often tell you the best case scenario, but don't talk about time constraints, or don't talk about what to do if your patient can't afford it, or don't talk to you about what you should do if your patient's on night shift. Our goal in delivering you a blueprint is that you actually get confident in clinical decision-making no matter what scenario is thrown at you, that you have the ability to take our work and plug it into your practice right away, but also with the confidence to make complex clinical decisions. So we've built everything for you, but also giving you the support and system that you need in order to implement it right away in your practice. So how do you join? So we offer a premium annual membership for the Confident Clinician, and that gives you access to our entire system on day one. So our whole knowledge base, it gives you a year of interactive learning. So all of the sessions that are up and coming, you get to attend live, but you also have access to everything we've ever recorded in the past. You get 360 support with our business stream, as well as our smart search, and access to 10 advanced training courses that actually take you through full training courses on day one. So you unlock that the moment that you invest in a premium membership. We've put the link for how to join in the chat, and I am going to walk you through what that looks like just so you can see on our end how you're going to join that membership. Our premium membership is $13.97 for the year. And like I said, it gives you, it unlocks all of those features that we talked about to immediately save you time, help you practice better, and be more effective in your practice. That link and come on over to the Confident Clinician information page. You'll see, and if you are a details person, everything that you need about why you need to join and what's included and how you'll feel is all on this page. including some amazing testimonials from our community. I showed you lots of our screenshotted testimonials, but we've got some great videos about how people have implemented our system into their work and how dramatically it's changed the way they feel about their work life. So all the inclusions are here. You're going to scroll all the way down to the bottom and you're going to click the sign up. You're going to choose your currency if you're a Canadian doctor or if you are tuning in from elsewhere in the world. You're going to choose your currency. It's going to pull you over to the checkout page, which again lists all of those features that are included in your membership. And the moment that you sign up, you unlock access to all of those features that we shared through the webinar. Okay. So questions, and some of you have been sending questions anonymously as I go along. So one of the questions was, what if I don't have time for this? So this is a really good question. And I will say, as a doctor who used to be stuck in the throes of one-on-one care, I deeply understand that it always feels like every time you have to make a change to your practice, that it's going to cause more time, it's going to be less efficient, it's going to be more difficult. Right? I was that doctor who wouldn't take half an hour out of my schedule to learn about something new because I felt like it was going to interrupt my flow. But the more complicated medicine gets, the more we need to leverage technology in order to make our lives easier. And what this resource offers is actually a solution to a problem that we've all just accepted as part of our industry standard, right? It's an industry expectation that you spend time doing patient research and you look stuff up for every individual patient you see, right? It's a full out expectation that you charge an hour of your time and then spend another hour charting. This is one of those investments that if you make a little bit of a time investment, you will gain back hours and hours a week. We have done calculations for our clients to see how much time we're saving them. It's an average of about 3 to 5 hours per week between our smart search, building referral letters, not having to look anything up, getting consensus-based answers on how to treat things, just feeling more confident in the work that you're doing so that you don't have to look anything up. We save people about 3 to 5 hours per week projected over the entire year. So this is one of those things that's like, if you don't have time to meditate in the woods, you need to go double. If you don't have time to use TCC, I promise you that the time you gain back from using this resource will change the way you feel about your work and help you be a more productive and probably happier practitioner. Okay, another question. What if you're not good at tech? So our tech platform's very simple. It's a very user-friendly experience with many ways of accessing the content. So there are the deep dive lectures, there's the at-a-glance sections you can read, there's the smart search bar. If you're not a tech-savvy person, you intuitively will be able to find the information that you need. It's very well laid out. You don't need any additional tech skills or training to use the information that you find on Confident Clinician. It is a very user-friendly experience. Yes, the registration is open year-round. So in the past, we had done cohort-based enrollment where you could only join us twice a year. We've changed slightly so that you can purchase an annual or premium membership at any time. And the reason we made the change is because twice a year we offer a live event for our members. And what was happening is that when people could onboard at any time in the year, we worried about dates and whether or not they were going to miss them. We've solved that problem. And with our annual premium membership, you get 2 live events in your 365 days with us. The one that's coming up next is our obesity medicine grand rounds, followed by our longevity grand rounds happening in the fall. So people that join, I just got a notification, someone just joined. Oh, 2 people just joined. Then you'll get access to those live trainings as part of your experience with TCC. So we are open year round. Those courses typically sell for $300 to $500, depending on when you hit the early bird sales. And so if you join, you essentially get those as a bonus for being in the community. They're great events. They're some of our favorite times we spend with our community for the whole year. Okay, another question. Do we offer continuing education? We do. We do. So our goal is just for you to be a better doctor, right? To save you time, to be better in practice, and to elevate the care of integrative medicine. However, we know that doctors like to speak in the currency of CE, and we don't want you to not be rewarded for the time that you spend with us. And so we do have many continuing education credits that are in Canadian and American associations. If you have a specific question about that, you can find some information on the information page that we shared with the link. You also are welcome to send us an email to ask about your specific unique circumstance. But we do, even though we don't identify as a CE company, we do offer continuing education for people we do offer continuing education for people depending on what state or province you live in. Is there a way to have a free trial before buying? So you can try our AI which is our smart search, for a free trial before purchasing. There are lots of other offers in the database, and they are only unlocked once someone commits to an annual membership. I would say if you're feeling hesitant or if you feel like it's a big risk, then wait until July when we do our regular onboarding for clinicians. That's when we showcase much more content. We give you a little bit more of a BTS, other parts of the program that you may want to utilize. But in between those sessions, the free AI trial is a great way to get access to some of the content, see the style and a level of engagement that we have with our content. And then if some of the business trainings and whatnot are things that are more up your sleeve, then July is a great time to get more information about those pieces. We like to think, the price point for TCC is really about one high quality new patient that stays with you all year because you've dramatically changed their life, or it's about 4 new patients that you get in the year that you otherwise wouldn't have had because you learned something new, you become better known in your community, or you end up, doing a webinar on something that we've done a teaching on. The price point on it is designed to have an immediate return on investment for clinicians, and you should feel it in your work every single day that you're working with your clinician, with your patient population. So, okay. Last question. Oh no, there was another question about time. We answered all the questions about time. Any other questions that we can answer for you before we hop off for the day? And I saw there was a message from Alexa saying, thank you. I love TCC. I'm on the website every single day. Yeah, and that's such a good point that she brought up. So we have about 500 doctor logins every single day. And so people use it at work. The tab is open. It's part of their ongoing workflow. We know that our clinicians are using it every day. Those are a great opportunity. It's a great opportunity for you to up-level your work. People are posting lunch and learns. Yeah, so our live training is delivered on Wednesdays at 12 p.m. Eastern. There's typically 2 per month, although this month we offered 2 additional trainings. And so even though if you can't make those sessions live, they get added to the database and get added to the knowledge base. And so this Wednesday, we're doing a session on gender-affirming hormone replacement therapy. If you miss that session, that information is searchable within the next day of it being delivered, and you can obviously watch the deep dive video when you have the chance. But we always encourage our clinicians to come to the live training as much as they can because it's such a great community experience and allows you to ask your questions live when you attend live. So that's what you're seeing when you see all of our hundreds of doctors online on Wednesdays at noon, is that's the timing for all of our Confident Clinician content to be delivered. Very consistent about it because we know we like to respect your schedules. So whether it's 9 a.m. PST or 12 p.m. EST, someone else just joined, which is great. We want you to be able to set a time in your calendar. So this month we did burnout, we did a session on binge eating, and we're doing a session on gender-affirming hormone replacement therapy. And so you get to pick and choose the topics that make the most sense for you. Someone asked a question about niching, and I think that's a great question. People always ask, well, what if I'm niched? And the question I always ask back is, if your patient who comes in, let's say you're niched in menopause and your patient comes in with asthma, do you turn them away? right? Or if you are niched in fertility and your patient also has acne, do you say, no, that's where I draw the line. That's not where I help. And so we have this ongoing debate in TCC of who needs TCC more, the generalists or the patients or the practitioners who are niched. And it's a 50-50 split because the niche-based practitioners are so embedded in their craft that they often have the least amount of time to spend looking at research on general health complaints. And yet they have nowhere to go to find the level at which they practice in their niche. There's nowhere to go to find that same level of information about another topic. And yet with TCC, this is exactly what we've provided. By being that reservoir of information, you can go and find high quality, high level information on any niche. So if your patient comes in with something different or new or a secondary complaint, or they want you to see their partner, that you actually have the skills and tools to be able to do it without having to reinvent the wheel and get back inside the research yourself. So there is a lot of content on different niches. The way that the dashboard is set up is very much like a medical database where you can go each medical subspecialty for all of the topics. But really, if we think on a broader scale, the goal is for all of us to be practicing at an elevated level of medicine. And if you've got a niche and your patient comes in with a new question, I want you to have that information at your fingertips so that integrative medicine shows up with the level of evidence that we deserve to. Okay, great question. Does TCC only pull from within the website's content? And the answer is yes. So for us, integrity of our system is incredibly important. We have trained our smart search is an AI built solution for our work, but it does not ask the internet to fill in the gaps. So if you search something, a rare condition that your cousin has, we may not have any information on it, and our smart search bar is very clear about that. It'll say, we've never covered this topic before. But it keeps the data internal. And the reason we chose that is that research on integrative medicine has never been easy, right? It's never been easy. Our work is buried in full text papers. It's buried in the methods of a paper. It's never been easy to research. And most of the publicly available research tools and publicly available AI-based tools are reading abstracts, they're reading blogs, they're reading Harvard Health, right? They're really not getting into the depth and level of evidence that we have as an industry. And so our search tool actually only looks at our content and our dialogue to be able to give you an answer. And if it doesn't know the answer, it will say. But that's a safer approach than it reaching into the depths of the internet and say, oh, this is what you do for esophagitis, right? It only gives you our answer, which we have lots on esophagitis. So that's a great question. And I think data integrity is something that's going to come up over the next couple of years in the world of AI, which I am deeply entrenched in these days. The data integrity in your clean data set is going to be the next big conversation in AI. Nobody wants a picture with like 19 fingers. You don't want a treatment plan that's asked the internet what to do, right? That's really no better than what your patient has access to. All right. Thank you so much for spending time with me this afternoon. So thank you so much for being here. I really appreciate all of your active dialogue in the chat. It's been so great to spend time together, and I will see all of you next time.